This section of the module will cover posture. Please review Chapter 16 in your textbook in addition to listening and looking over the PowerPoint slides in this presentation. The objectives of this chapter are to define normal standing posture for the sagittal and frontal views and to identify postural deviations at all joints. Posture can be defined as the orientation of the body segments to each other in a relatively static position. Several factors can influence posture, such as body type, habit, disease, and genetic anatomical predisposition. This chapter reviews normal posture and abnormal standing posture in the sagittal and frontal views as shown in the figures. Normal posture is probably a misnomer in that most people do not possess normal posture. However, by identifying normal or ideal posture, the clinician has a standard posture against which to make comparisons. The majority of postural analyses are performed with the client standing. This section presents normal standing alignment in the anterior, posterior, and lateral views. The dashed line in the figures represents the plumb line, or reference line to postural normals and abnormalities. When assessing anterior posture using a plumb line, the plumb line should bisect the body into two equal halves. The alignment should be such that the line is equidistant between each eye and ear, bisects the nose into equal halves, bisects the chin, bisects the sternum of the chest, bisects the umbilicus or belly button, is equidistant between the knee joints, and is equidistant between the medial malleoli. When assessing posterior posture using a plumb line, the assessment will be similar to the anterior examination where the body is divided into equal halves. The alignment should be such that the line does the following: bisects the cranium into two equal halves, is equidistant between the scapula, is equidistant between the posterior superior iliac spines, is equidistant between the knee joints, and is equidistant between the medial malleoli. When assessing lateral posture using a plumb line, the following alignments should be noted: slightly anterior to the lateral malleolus, just in front of the center of the knee joint, through the greater trochanter of the femur, slightly posterior to the center of the hip joint, midway through the trunk, through the bodies of the lumbar vertebrae, through the shoulder joint, through the bodies of the cervical vertebrae, and through the lobe of the ear, through the external auditory medius or the ear hole. Any deviation from the plumb line is considered to be abnormal posture. Common abnormalities will be discussed next in the presentation. During a postural evaluation, the positioning of the femur should be straight without excessive transverse plane motion or an inter or external rotation. If the person presents with the knees touching and the feet apart, this is indicative of genu valgum or knock-kneed, as shown in Figure A. Excessive gapping between the knees with bowing inward indicates genu varum or bow-leggedness, as seen in Figure B. When evaluating posture in a lateral view, assessing for spinal deviations is important. There should be a slight posterior curvature in the thoracic spine. Abnormalities include an excessive posterior curve, termed kyphosis, as shown in Figure A. Pay attention to the scapula, as their position can give the illusion of a thoracic kyphosis. The lumbar spine should have a slight lordotic or anterior curvature. Excessive lordosis may be present in people who have hypermobility, which can be accompanied by tight hip flexors. Figure A also shows what excessive lordosis looks like. It is possible to have both deviations of the spine at the same time. Some people present with minimal to no lordotic curvature of the lumbar spine, which is termed a flat back and is depicted in Figure B. These people usually have very stiff lumbar spines. The sway back posture, shown in Figure C, is found in people with a flat lumbar spine and where the thoracic spine is swayed posteriorly relative to the plumb line. From a posterior frontal plane view, the spine can have another type of deviation known as scoliosis. This can affect both the thoracic and the lumbar segments. Figure A is what a normal spine would look like in this view. Figure B shows a right thoracic scoliosis. Figure C is a left lumbar scoliosis. Figure D is a right thoracolumbar scoliosis, and Figure E is bilateral scoliosis, which is a right thoracic and a left lumbar deviation. Keep in mind that these figures represent only right or left of each deviation respectively. These postural deviations can occur to the opposite side from the figures shown. Vladimir Janda, a Czech physiatrist, introduced the concept of neuromuscular imbalances between groups of muscles resulting in poor posture, loss of mobility, and an increase in joint loads. His theory states that certain muscle groups tend to be either tight, referred to as tonic muscles, or weak, referred to as phasic muscles. Muscles prone to tightness generally have a lowered irritability threshold and are readily activated with any movement, thus creating abnormal movement patterns. Abnormal movement patterns can lead to dysfunction and pain. Two of the specific types introduced by Dr. Jonda are the upper cross syndrome and the lower cross syndrome. The lower cross syndrome, seen in Figure A, is characterized by tightness of the thoracolumbar extensors on the dorsal side or back that crosses with the tightness of the iliopsoas and rectus femoris muscles, which are the primary muscles that perform hip flexion. Weakness of the deep abdominal muscles crosses with the weakness of the gluteus medius and maximus muscles. The upper cross syndrome is also referred to as a proximal or shoulder girdle cross syndrome and is shown in Figure B. In this syndrome, tightness of the upper trapezius and levator scapula on the dorsal side crosses with the tightness of the pectoralis major and minor on the front side. Weakness of the deep cervical flexors crosses with the weakness of the middle and lower trapezius. This pattern of imbalance creates joint dysfunction, particularly at the cervical spine, the thoracic spine, and the shoulder joint.